Hi, everyone. We'll start the webinar in just a few minutes. We're still letting people join. All right, let's get started. Welcome, everyone. My name is Liz Watkins, and I'm the Provost and Executive Vice Chancellor here at UC Riverside. And I'm joined by my colleague, the Vice Chancellor of Research and Economic Development, Rodolfo Torres. He'll be moderating the Q&A section of our presentation. I'd like to introduce to you our guest presenter, Dr. Natasha Martin. Natasha is an associate professor in the Department of Medicine and the Division of Infectious Diseases and Global Public Health at UC San Diego. And she's epidemiology program leader for UC San Diego's Return to Learn Steering Committee. Since March 2020, she's been developing models of how SARS-CoV-2 might spread on campus and in San Diego. Her recent models address possible on-campus infections based on the percentage of faculty, staff, and students who have been vaccinated. Martin also holds an honorary senior lecturer position at the University of Bristol. She's also the co-director of the Biostatistics and Modeling Core of the UC San Diego Center for AIDS Research. She's worked for 18 years developing mathematical models of disease progression and transmission in both communicable and non-communicable diseases. Now, the plan for today is, in just a second, I'll turn it over to Dr. Martin, who will present for about 20 minutes. We're leaving plenty of time at the end for Q&A. As I said, that'll be moderated by VC Red Torres. So please submit your questions using the Q&A box. You may also upvote questions in the Q&A box. This presentation is also live streaming to our UCR YouTube channel, and the recording will be posted as well, so you can tell people who weren't able to attend live that they can watch it later. And now, over to you, Dr. Martin.
Thank you so much, Provost Watkins. It's really a pleasure to be here today. Thank you so much for the invitation. So today I will be talking about some work that we have been doing at UC San Diego, really using simulation modeling to try to understand what might happen in the fall and use that for contingency planning. Can everyone see my slides? Okay. Okay. One thing I just want to note is that this work really was done by a fantastic junior faculty member here, Ravi Goyal. He's the one that was the engine behind the modeling. So I wanted to give him particular credit, as well as my collaborators on this slide. So at UC San Diego, we developed this Return to Learn program and to address the COVID pandemic. And it was really designed conceptually to have three pillars that would promote on-campus safety: viral detection, public health intervention, and risk mitigation. And there are a number of components of each of these pillars, but as we're thinking towards the fall, of course, one of the key cornerstones will be what you see on the right-hand side here, vaccination. So we'll have a very aggressive vaccination program, but we'll be combining that with the other efforts that we have in terms of viral detection. So our testing program, our environmental monitoring, our wastewater monitoring program, which I'll talk a little bit about today, as well as, of course, our daily situational monitoring that allows us to monitor the situation on campus every day and adapt as the situation and as our understanding of the epidemiology and the disease changes. And so this interdependent and adaptive approach has really served us well this year to be able to be nimble and flexible to the COVID pandemic, and also kind of to stay one step ahead of the virus. So as part of this science-driven approach, one of the things that we have tried to do this year is use simulation modeling to predict what might happen on campus in order to inform our understanding of areas which might be at higher risk of COVID, as well as just thinking about how we can strengthen these three pillars in the best way possible to improve campus safety. So we developed what's called an individual-based network transmission model, and I'll go into a little bit more detail about that in a moment. But basically, it simulates SARS-CoV-2 transmission among individuals in our UC San Diego population. And it was really tailored to the campus configuration, and it was used when we developed it last summer to inform the COVID strategy, again, using this data-driven adaptive approach. So there's information of this model that is on our public website. As you can say, you can even play around with the model and the results on that website. But this last year, it played a really critical role in decisions regarding housing density, classroom instructional modes and campus classroom sizes, testing frequency for our asymptomatic testing program, as well as helping us understand our isolation housing need, and more generally, just understanding what kind of data collection we needed to track and better inform our understanding of COVID epidemiology on campus and predictive modeling. And so this model, as I mentioned, is an individual-based model, which means that it simulates each individual. That is for UC San Diego, our 60,000 individuals, both on and off-campus students, as well as faculty and staff. And so it simulates these interactions, and the interactions happen on what we call networks. And that's what I'm showing you here on the left-hand slide. So the circles here are individuals, and they're coming into contact with other individuals. Here I'm showing a network for our on-campus residential student. You know, they may potentially share a room with a roommate. Those rooms there may be multiple rooms within a suite that have a shared bathroom or a common area. Of course, suites are situated within our buildings. And so we actually tailor the model to the specific configurations in terms of our buildings and our suites down to the room level on campus. As well, we incorporate network interactions of classroom interactions. So we have students that can interact with faculty within classrooms, and we use actual class registration data to inform our understanding of the sizes of these classrooms and how they're distributed depending on level of student, for example. So along with these fixed networks that we assume do not change over the course of a term, right? A student's residence stays fixed, a student's classroom registration stays fixed. We also simulate what's called these campus connections, which is kind of a random network of interactions that people randomly come into contact with other people just through walking around campus, getting lunch, for example, or social interactions around campus. And so these are all these three different types of interactions, these residential interactions, these classroom interactions, and random campus connection interactions are all where we look and simulate campus-related transmission among our UC San Diego population. But as well, we also assume that every person has this external risk of acquiring infection from the outside community, from just going outside into San Diego, going to the grocery store, or maybe even going home and seeing their families off campus. And in fact, the vast majority of the infections that we've seen this year have been those what we call community interactions. And so we have that community risk of infection among all our individuals as well. So we have these networks that individuals can acquire infection, and the model also simulates the natural history of infection through various stages of asymptomatic or symptomatic infection. And of course, we incorporate the fact that we know that individuals can be transmissible even in their asymptomatic phase. And now we've built out the model so that we can incorporate vaccination, and assuming that individuals who are vaccinated have a high amount of protection of both acquiring and transmitting infection, as well as severe disease and mortality. And so we use this simulation model as an engine to try to probe different hypotheses and test different scenarios of what might happen with different levels of vaccination or intervention strategies. And the outcomes that we're looking at are things like total campus-related transmissions. How many transmissions do we expect to see over the course of a term that are related to these campus interactions that I mentioned? And how many infections might occur over the term due to community, external interactions? I mentioned those community outside the UC San Diego community. We also look at isolation bed need. And because this model actually simulates each individual, we've also used this model in the past to look at things like outbreak sizes, or after a single introduction, how large does that infection cluster get, and where do we see the larger clusters? I won't talk so much about that today, but we have used the model for that, which is kind of what I'm showing you on this slide here in terms of cluster sizes. And you can look more into detail on our website if you're interested in that. Okay, so the goal of the work that we've done more recently is to inform the contingency planning for fall 2021 using this predictive modeling with plausible worst case scenarios. So we can't predict exactly how many infections there will be November 27th, but we can say with our plausible guesses of worst case scenarios, what might we expect? And so the scenarios that I'll be discussing today are ones where we have looked at things like, how does increasing density on campus affect the amount of campus-related transmission that we can anticipate? So we simulate the model, and we can simulate scenarios such as the current scenario right now, what we're on campus, which is singles housing only and hybrid instruction, where the majority of courses are remote and a small proportion are in person. We also simulate a scenario of singles housing, but in-person instruction, to look at the potential impact of bringing more students on campus and having more of those campus-related classroom-related encounters. And we also simulate a scenario increasing housing density. So what happens if we increase housing to doubles housing, as well as having in-person instruction, which is where we plan to be on campus. And we can also look at things like triples housing. We used to have that. We were never planning on going back to that because we've brought on more buildings, but we have used the model to look at, the impact of even higher levels of density. But the main point is to say, if we had increased the residential density as well as classroom interactions on campus, what can that mean in terms of transmission? These scenarios also incorporate full density of employees and staff on campus, knowing that that's what we're aiming towards in the fall. So as I mentioned, we also incorporate vaccination. In these particular simulations that I'm showing you, that I will show you, we assume 75% vaccination coverage among students and employees at the start of fall term. This looks to be a reasonable, plausible worst case assumption, because just this week, we can see that at UC San Diego, we do have about 75% of our employees, as well as about 70% of our on-campus residential students who have already been vaccinated. So we anticipate that it will likely be higher in the fall. But again, this was our worst case scenario assumption. And for these scenarios, we assume that being vaccinated is associated with an 80% reduction in acquisition or transmission of the infection if vaccinated. Again, the data that we have indicates this is probably more likely to be in the sort of 90-95% efficacy, particularly with the mRNA vaccines. But we use a worst case assumption of 80% in these scenarios. And we also have used the model to look at various impact of different testing strategies. So we look, I'll show you different assumptions of asymptomatic testing strategies from weekly to every other week, with and without our wastewater monitoring program, which I'll talk about in 1 minute. And for these particular scenarios, we currently include masking outside of the residences. We are rerunning some scenarios right now, looking at what if with the new guidance in terms of vaccinated individuals do not need to mask, then we'll look at the impact of that. But I actually don't anticipate that would likely change the results markedly with the high levels of vaccination that we are exploring in this model. So just one comment about our wastewater monitoring, because it is part of the simulation modeling right now. So on campus right now, we have daily wastewater monitoring from 126 wastewater sensors that collect wastewater from over 340 buildings. So we collect the wastewater every day and process it. And what we have found is that the wastewater is highly sensitive in detecting infected individuals. So we have been able to detect a positive wastewater signal in a building with several hundred residents, and then subsequently identified one asymptomatic individual. So it's very sensitive. in our analyses over the course of the year, depending on the term, has shown that it's between 74 and 87% sensitive in detecting residential cases. So 74 to 87% of residential cases were also detected in the wastewater. The information that we have is provided on our public daily dashboard, as you can see here on the bottom right. And the wastewater, what we have found from other analyses that we've done is that notification that your building is positive actually doubled the testing rates in that building. So we know that not only is the system sensitive in detecting infections, but that the notification that building is positive does lead to increased testing in that building and helps us diagnose individuals earlier and isolate them to prevent further transmission. So based on these data that we've collected, we incorporate that impact into our simulation modeling and layer it on top of our asymptomatic testing scenarios. And finally, the last thing that I think is important to mention about the model, how we've modeled, is that we have calibrated the model to the data that we've acquired this year in terms of where we see likely transmission occurring among our populations. So this slide shows you from our case investigations, our best guess in terms of the where we see the transmissions occurring. And what you can see is that the vast majority of cases, over 85% of the time, appear to be community acquired. So known exposures in the community and known exposures when they went home to see their families. The vast majority of the cases we see, not just among students, but also faculty and staff, have likely been community acquired. And we have had very few transmissions, which we believe could be campus related. We have had no classroom or research related transmissions at all this year. Of course, we have had much reduced density in those settings, but very promising, we haven't seen any evidence of transmission in those areas. And so we use this information in terms of where we have seen transmissions so far to calibrate the model in terms of our understanding of the relative risk of transmission in these different types of settings for fall 2021. Okay, and so here are some of our results. So this slide shows you the total cumulative number of predicted transmissions over the course of an entire term that we anticipate in the fall among our whole UC San Diego population of 60,000 individuals, assuming 75% of our employees and students are vaccinated at the term start. Now, the red bars here show you the anticipated campus-related transmissions, and the gray bar, the anticipated community-related, externally acquired transmissions over the fall. And so what you can see is that comparing just the red bars to the gray bars, we anticipate, as we have seen over the entire course of this year, that the vast majority of our infections will likely still be acquired in the community and not due to any campus-related transmission. The campus has been and will continue to be safer than the community and a safer place. Now, the second thing to note is that these different clusters of bars show the impact on those cumulative number of transmissions as we move from less density on campus, singles housing and hybrid instruction, all the way up to very high density on campus. This is a scenario on the right of triples density and full in-person instruction. Again, all these scenarios include full density of research staff, faculty, employees and staff. And so what you can see here is that even in the context of increasing campus density from the left to the right, there are predicted to be very few campus-related transmissions over the course of the term, less than 20 over the course of a term. So we're talking about 1 to 2 per week in the fall. So we do not expect there to be many campus-related transmissions. Yes, there is a slight increase in the amount of campus-related transmission as we increase density on campus and activities on campus. But you'll also notice that those gray bars decline. So we're bringing more people on campus. We maybe see a slight increase in the number of campus-related transmission, but we see a decrease in the number of community transmissions because we're taking people who are living off campus and bringing them onto campus, or working or socializing off campus and bringing them onto campus. So overall, we actually don't anticipate that there will be a marked difference in total number of infections with these different density scenarios. So very promising in terms of what the cases we anticipate in the fall. I know this is a busy slide, so I'll walk you through it slowly. This slide essentially looks at within a single scenario. And here I'm showing you doubles housing and in-person instruction, which is where we plan to be in the fall. What is the impact of various levels of monitoring strategies on the total cumulative detected cases shown at the top and transmission events shown at the bottom? And so what you can see here is that there were actually minimal differences in the number of detected cases, which are in the blue bars here. Blue is detected and black is undetected. There are really minimal differences in the number of detected cases, regardless of asymptomatic testing strategy. So these different bars just show different combinations of weekly or every other week asymptomatic testing of those who are not vaccinated, with or without wastewater monitoring. And you see, really less than 10 differences in the number of detected cases over the term, depending on these different scenarios. Now, there are fewer cases that are detected in a scenario where we only do wastewater monitoring. So this is where we would monitor the wastewater daily. If we see a positive signal in a building, we would send out a notification and encourage individuals in that building to get tested. So in this scenario, we see slightly fewer cases that are detected, on the order of about 15. But if we look at the impact on the number of campus-related transmission events, we can see that there's basically negligible difference between these scenarios. So, really, I think just pointing to the fact that we may be able to relax slightly on the frequency of asymptomatic testing and still know that we have the ability to detect infections through other means such as wastewater monitoring and testing of symptomatic infection, which I think is very important in the fall in terms of detecting infections and preventing transmission. At UC San Diego, the wastewater will remain a key component of our monitoring strategy in the fall. So just to summarize, I think the modeling using, again, these plausible worst case scenarios really indicates that with high levels of vaccination, as we anticipate to be the case in the fall, there are few expected campus-related transmissions, even with increased density and activities on campus. These are plausible worst case scenarios for contingency planning. And, of course, there's discussions of a mandate if there is mandatory vaccination. And we, as we anticipate with higher levels of vaccination coverage, you would expect even fewer numbers of transmissions than the ones I've shown you today. So I think that is all very optimistic. There are two important limitations of this work that I'll mention. One is that these simulations, as I mentioned, only include masking outside of the residences. We are currently looking at that to look at what happens if vaccinated individuals do not mask or if there's a reduction in masking. Again, I think with high vaccination rates, that's less likely to have a marked impact, especially if the vaccination rates are, as I believe they're going to be in the fall, which is much higher than 75%, hopefully 90-95%. And the other thing to mention is that this work does not include the impact of variants. The variant question is something that I think we will just need to continue monitoring on campus. One of the things that we're doing at UC San Diego is sequencing both individual testing as well as our wastewater positive samples so that we can identify whether there are variants of concern on campus and examine, whether they're spreading on campus so that we can, adapt our approach accordingly if we see a variant arise that's of particular concern that appears to be spreading quickly in our community. So I think in general, the situation looks good for the fall, and we'll use the strategies that we've developed successfully to keep the campus safe this year, moving forward into fall 2021. And with that, I'll hand it back to Provost Watkins.
Thank you, Dr. Martin. It's very enlightening. I really appreciate the work that you've done at UC San Diego and for sharing it with us here at UC Riverside. I'm going to turn it over now to Rodolfo and ask him to field the questions. And those of you in the audience, please write your questions in the Q&A.
Thank you, Lee, and thank you, Dr. Martin, again. Very interesting presentation and very, very informative. As Lee said, please make sure to type your question on the Q&A box, and you have the ability to vote them out so we can move them out the most favored ones. There was a question about masking. I think you just answered it, that the model, I believe, assumed that outside the resident hall will be wearing mask. One question before we go to the other I have in general. I know you mentioned several times this is based on particular configuration at UC San Diego and so on, but I assume a lot of these can be generalized, right? Can you elaborate on this, how broad this is that can be, to some extent, inferred that will apply to other campuses?
Yeah, it's a great question. So you're absolutely right. The model itself is, as I said, really tailored to the specifics of the UC San Diego residential and classroom kind of configurations. Having said that, I think the broad conclusions of the model that, we anticipate that the transmission is likely to be much lower in the fall, very low, and also that the campus is a safer place in the community is highly generalizable to other UCs. I mean, we've seen that across the UC system, that the campus has actually been a safer place in the community, that we've done a great job at keeping campus transmission low and not having transmissions in the research or the classroom setting. And so I think that the general findings are generalizable, even though the nitty-gritties of how many students live in a room and how many rooms to a suite, are slightly different campus to campus. I do think that the absolute numbers in terms of the number of infections that you would expect, of course, that would scale by the campus population size and will be strongly dependent on the community infection rates. Again, also going back to the point that the majority of infections that we've seen and across the other UCs, I think is the case as well, really have likely been acquired outside in the community. So that will all be kind of community dependent, but the general conclusion that, the campus is a safer place and we can think about resuming on-campus density and activities in the fall, feeling pretty good about that with high levels of vaccination, I do think are generalizable.
Thank you for that. Here's a question from the audience. Can wastewater monitoring be effective for buildings where there are a lot of different people coming and going, such as university common or libraries?
That's a great question. So I think that there are two really useful ways of thinking about how wastewater monitoring can help us in this pandemic. The first is how I was talking about it today, that you could use wastewater monitoring of a building to notify those building residents or the people working in those buildings that they're potentially infected and get them tested. In terms of the buildings that we've seen which had public bathrooms or may have had a lot of turnover, as you mentioned, like libraries, that was one of the reasons why we worked so hard to get the information that we had published on our public daily dashboard, so that anyone who went into those buildings that day could check the daily dashboard and see if it was positive. And, obviously there are people that are coming off campus as well, accessing those facilities, and we anticipate that to happen even more in the fall. And so in order to be able to get that information out there, we put it on our public daily dashboard. We also do have email notifications of people that are specifically working and living in those buildings so that we can have a more direct link to them, because we know that maybe they don't check that dashboard every day. But the second way that wastewater monitoring can be helpful is not necessarily for individual notification and trying to identify, let's say, a single infected individual, but it can also form of a type of passive surveillance, right? Where we can kind of just monitor the amount of viral activity on campus and whether that seems to be increasing or decreasing over time. And so, monitoring, for example, a very public space like a library could just be a way of a university to monitor, do we see changing trends in activity and something that's concerning? And as I mentioned before, if you're able to sequence that wastewater, which we do have the technology to do now, then you could also see whether there were indication that there was sort of variants that were present that needed to inform your response. So I think that both of those are good ways to think about how you could use that wastewater monitoring program.
Okay. So here is another question about the modeling and some of the things you take into consideration. So does your modeling include consideration for ventilation? What are your thoughts regarding transmission through HVAC systems?
Yeah, that's a great question. So our The model that I presented today does not simulate ventilation and characteristics of the room, but we do have a separate suite of models that were developed by a professor here that simulate ventilation and the risk of transmission within a specific building. And they've actually gone from room to room to kind of measure ventilation and air change turnover and use that to try to understand and optimize those characteristics. So that's incredibly important and is a separate kind of suite of modeling that we've been doing on campus to try to understand what we need depending on different sizes of rooms, different types of ventilation systems, and the activities going on in those rooms that has helped inform our strategy. In general, of course, we have been working, the university has been working really hard to improve and ensure that those systems have adequate ventilation. And I think the truth is that we anticipate, again, that case rates will be very low in the fall. We've been seeing them decline across California really strongly over the last few months, predominantly due to behavior, but predominantly due to vaccination. And so the individual risk that somebody will be walking into a classroom that's infected is going down every day, or walking into a building is going down every day. And so that combined with our strong risk mitigation and ventilation efforts, I think will be what we need in order to keep the campus safe in the fall.
Okay. Here is a question about, you mentioned that you have experienced that most of the transmission has happened through community transmission, as you describe it. And well, I think it has been the same in our campus. We have seen very little in terms of transmission on campus. So there's a question of whether how the model will react, or what is your prediction if there is a big increase in, let's say, 10% or some number of the number of students that commute to campus. If they are having an increase in that, how the model will be, the outcome of the model will be affected.
So the simulations that I showed you actually assumed full density of students coming to campus for classes, and so in that sense, I think it's fairly conservative because we know that there's going to be a fraction of students who either cannot get back to the UC San Diego community, either due to visa restrictions, or they choose to stay at home and take their classes remotely this year. So our simulations actually kind of assumed that all those people would be coming on campus. So you'd expect even fewer of transmission events if we had some that did not come back to campus. But in general, I would say to that question that, of course, the more students that we bring back on campus, the more likelihood that there may be transmission events occurring because of probably individuals bringing infection onto campus and potentially resulting in transmission. But, with high levels of vaccination, even if there are individuals that are infectious that come to campus, it's going to continually reduce the risk that anyone else acquires infection from them. And so the more we can get our populations vaccinated, the more it protects us from transmission, and the more that we can reach what everyone is talking about, which is this idea that if you have very, very high proportion of your population vaccinated, then you can protect their indirect benefits on the individuals who are not vaccinated because they are kind of protected from the herd. So that's really important. But of course, I think that everyone, just to say that although we have 75% of our employees vaccinated, that does mean that there's 25% who are not vaccinated. And we need to, encourage everyone to get vaccinated if they can. And, and in the meanwhile, maintain masking and vigilance so that they don't acquire infection and transmit it to others.
Okay. So here's another question about space occupancy. I think you're assuming full occupancy, but just in case, does your model or other ones take into consideration common area and shared space, for example, in offices? And if so, does the density of occupancy affect the model?
Yes, that's a great question. So again, we simulate that there would be full density of individuals coming and working on campus, and it simulates interactions between these different types of populations depending on shared spaces. So for example, in classrooms, you would have both the faculty member as well as the students there. It doesn't get down to the level of shared common spaces or offices within a building. That's a good question. We didn't have the detail. We did not build out the model in terms of the detail of particular office configurations for the employees. So it doesn't get down to that level of detail. But I would say overall, I think the conclusions are similar in terms of if we can reach 75+% of our employees vaccinated, then we have a very low risk of transmission and high level of protection for those interactions. And so just ensuring that individuals who are in those shared spaces that are not vaccinated maintain masking, I think will be the critically important point in the future, and get vaccinated if they can.
I'm glad that you keep on repeating getting vaccinated. I think that's the message we send, we need to send around. So I know this is maybe oversimplifying thing, but if there's one parameter that you can control and that will have the most effect on the reduction of transmission, would you say is that vaccination or?
Absolutely. And I wish I had, because I have the simulations. We've done the simulations for 95% vaccination. And in that case, it goes down from, let's say, 15 to 20 campus related transmissions on campus down to 1. Maybe. So the strongest impact that we can expect is proportion vaccinated. The more that we can increase the proportion vaccinated, the lower we'll drive down the risk of any potential campus related transmission. There's a really good question here that I'd like to answer that's related to this issue about vaccination and transmission, and that's about variants. So we are accumulating more information in terms of the effectiveness of the different vaccines against the variants. Some of the variants, in particular, the variants which were first identified in South Africa and Brazil and now India, share a type of mutation in a region called the 484 region. And what that mutation does is it means that the vaccines are slightly less effective against those particular variants. So that is a concern. But the good news is that the mRNA vaccines, so that's the Pfizer and the Moderna vaccines, are still strongly potent against those variants. So we do have highly effective vaccines that are effective even against the variants where we see slightly more concerning trends in terms of vaccine effectiveness. So again, get vaccinated. That's the most important thing. The fewer opportunities that we give the virus to replicate, the fewer opportunities we give it to develop a mutation that allows it to either be more transmissible or more lethal, or where the vaccines are less effective against them. So in terms of thinking about the potential risk of variants, I would say that the underlying point is that we need to reduce the amount of circulating virus in our community as well as in other countries by increasing vaccination so that we do not give the virus an opportunity to mutate into another strain where the existing vaccines are less effective against them.
Okay, thank you for that point. And we're still getting several questions about masking. I think you mentioned the model does assume that masks are being used outside resident hall. And I think on our campus, if people are by themselves, they're allowed not to wear a mask. Do you think that has an effect or could have an effect in the model and going forward? I think you say you're still studying what will happen if we remove masks from common places and so on.
Yeah, but I'm happy to talk more about the masking thing. And I know, it's a hot topic of conversation on our campus as well. So, generally there is discussion about what will happen in the fall in terms of the mandates for masking, and we're waiting for the state of California guidance in terms of higher education, which will come out in June, which will help us understand what at least the state guidance is in terms of masking. And we're also, learning about discussing with our faculty and our staff and our students on campus, just their feelings about it. We have some faculty that really, it's important for them to be unmasked in their classes so that students, language professors, the students can see them speaking, and others who feel differently about it. So we're kind of collecting that information to make that, science-driven and educational decision-making process. But in terms of the question about that I see about, relaxing mandates and if that is potentially dangerous in terms of the variant transmission. What I can say is that individuals who are vaccinated are at a substantially lower risk of acquiring infection and transmitting infection to others. Now, that doesn't mean that's zero risk. There is still some risk if you are vaccinated that you may get a mild infection, and you may be infectious to others. We've had a few, it's less than a handful, but we have had a few individuals infected here that were fully vaccinated and past 2 weeks after their second dose. What we've seen from those individuals is there's a few important things that we've learned. One is that some were asymptomatic, but some were symptomatic. So I think it's really important for even vaccinated individuals to maintain symptom screening, and if they're symptomatic, access testing, because you could be infected. But the other point I think is to think about that and think about what it means. It means that vaccinated individuals, there might be a small chance that they get a relatively mild infection. That's not really a risk to them, but it is a risk to people who are unvaccinated, and those who can't get vaccinated for reasons if they're immunocompromised. And so it points to, again, back to my other point, for those who are unvaccinated, you still are at risk. And you should get vaccinated to protect yourself, both from other people who are unvaccinated or potentially people who are vaccinated who may be unknowingly, infected with the virus. And so that's what I would say about that point. And in terms of the fall and the effect of variants and masking and how that will play, again, kind of to my last point, I think we need to continue doing what we have done so well this year, and that is monitoring the situation and adapting accordingly. So through our testing program, through our viral monitoring programs, and our molecular sequencing, we can see whether we see viral breakthroughs or people that are infected that have been vaccinated. We can see whether that's associated with a particular variant, and then we can adapt our approach accordingly in terms of our messaging. We have the ability to monitor that and to shift course if we need to, and shift our strategy. And I think that adaptive strategy is what we're going to need, because the truth is we just don't know. With the existing variants, again, it looks like the vaccines, especially the mRNA vaccines, are highly potent against them. So that's good. But it may be that a variant arises that is more concerning. We can't know. And the best thing we can do is just ensure that we have enough robust monitoring in place that if that situation occurs, we can respond accordingly.
Okay. There is a question about asymptomatic testing referring to low sensitivity. I'm not sure if that's correct. I think on our campus, we do in our own lab qPCR testing, and then Curative does also the same type of test, which I think is among all tests the most efficient. What type of asymptomatic testing you assume in your model? Is it qPCR or is it antigen test or something?
Yeah, so we on campus, we're doing PCR testing, and we simulate PCR testing. And I think in these simulations, we assume about an 85% test sensitivity for our PCR testing and a very high specificity. As we've seen, it's probably well over 99%, 99.5% for the specificity. I think it may be slightly lower for asymptomatic testing for the antigen testing, but there's been quite a bit of modeling that's indicated that regardless of the sensitivity of the test, testing frequency is the most important thing in terms of population monitoring. So if we can just ensure that for those populations who are not vaccinated, they participate in asymptomatic testing at a fairly, frequent cadence, regardless of the sensitivity of that test, that the benefits of that frequent testing outweigh any differences in test sensitivity.
Okay, so and I want to follow up on this because we're changing our protocol for asymptomatic testing, rounding them down from very intensive testing that we have been doing. And I think your model justifies that, right? It says that at least if people get vaccinated, you don't see much difference. I want to make sure I understood that. You don't see much difference whether people are intensively tested asymptomatically or not. Of course, symptomatic people need to be vaccinated. Is that correct?
That's right. Some of the modeling work that I didn't show you today, we used to look at the shift because we recently made a shift so that we're only mandating asymptomatic testing for those who are not vaccinated. So we no longer have a mandatory asymptomatic testing requirement for students who live on campus or are coming to campus if they are vaccinated. And the simulation modeling indicated that there was virtually, very, very minimal differences expected in transmission, like one transmission over a term, not testing those who are vaccinated. And then the results that I showed you today, you're absolutely right. Those simulations were comparing both weekly, every other week, or in fact, no asymptomatic testing and just relying on the wastewater and symptomatic testing, showing that there was likely minimal differences in terms of transmission events. Again, because we anticipate that there will be very few transmission events in the fall because of the high levels of vaccination.
Okay. Let's see. What is the risk if you had, I guess, the risk of getting infected again or of transmitting? What is the risk if you had COVID and have since been vaccinated?
Yeah. So the trials indicated that for the mRNA vaccines, they're incredibly potent in terms of preventing severe disease and mortality, 95% and above for the mRNA vaccines. And we're still accumulating evidence in terms of, as I mentioned, the risk of acquiring any infection and transmitting it. And that does appear to be slightly different based on the vaccination type. And it will probably be slightly different based on if the individual had previously acquired infection and was also vaccinated. So I don't think we really know the answer perfectly. What we can say is that the mRNA vaccines, as I mentioned, appear to be very likely to be 85, 90, 95% effective at prevention of acquisition and transmission of infection. The J&J vaccine, there's evidence that it's slightly lower efficacy, maybe 72% effective at transmission. The main efficacy trials were not powered to look at transmission. So we're still accumulating evidence in that area, but probably, especially with the mRNAs, it's likely to be over 90%. And again, there may be differences and in fact increased potentially immunity among individuals who have both been previously infected as well as vaccinated, but I think we need to acquire more information in that area before we know for sure.
And the two questions about, I guess I would say, activities or environments and, whether some area or some activity are more prone to transmission or exempt from that. We have seen really practically no transmission in the lab, for example, where perhaps condition of safety and people are very well trained about using PPE and so on, ideal. So is there a difference that the model will suggest? It show overall we will be pretty safe, but it will be even safer in this activity or maybe less so in some other one.
Yeah, so for sure, both our data and then subsequently the modeling are indicating that the highest risk activities are really the socializing ones, right? And we've seen that, in our campus, across university campuses across the US, that it's really the social activities that appear to be associated with the most transmission events that we can see among our campus populations. And I think it's been a pretty consistent finding across universities that classroom related transmission is very, very likely very, very low. Now, I will caveat that by saying, of course, we've had very few persons in class this year. So we don't have a lot of data, but there have been other universities that have had more in-person instruction in different states that also haven't seen, large classroom associated outbreak events. By and large, it tends to be the social activities that, historically have been unmasked and have been, just in that social area. So that was the risk. I think that will likely continue to be the main risk for campus-related events. But again, the vast majority of infections really are acquired off campus. They're acquired. So to date, there were, students going home to see their families and coming back. And across most of the UCs, we saw a surge in infections returning from winter break as students came back from break and had been with their families and brought back infections back on campus. And so I think that will be the same in the fall. And we just need to, again, encourage people to get vaccinated to reduce their risk of infecting and bringing it back on campus.
All right. So with that, I want to thank you again. I think you answered all the questions that people pose and then some more. And I want to make sure, since we are reaching the end of our time, that I give you some time out for your concluding remark or comments you want to make, and then probably our provost would like to say a few words too. Thank you.
No, thank you again. Thank you so much for having me. I think I'm just here to say that just a little flag for modeling. I think that these types of modeling exercises can be really useful to help us just try to think about what it might be like in the fall. And again, although all of this work was done based on UC San Diego and calibrated to our situation, I think it is quite generalizable across the campuses to say that, it's been a long year, but the light is at the end of the tunnel. And if we can just get people vaccinated, we should anticipate that we can kind of resume as much of normal campus activities as we can in the fall and get back to what we all want to be doing, which is, doing research and teaching and having in-person interactions. So thank you again for having me.
Thank you very much. And Liz, the floor is yours.
Thank you, Dr. Martin. I found your research to be fascinating, and I found your results to be very reassuring. So thank you so much for sharing them with us. Thank you to Vice Chancellor Torres for joining us and for monitoring all of the questions. Thanks to all of you in the webinar who joined and for asking your questions. Please know that the information on our return to campus is always being updated on the website campusreturn.ucr.edu. Thank you all again for joining us. Thanks to Dr. Martin. Have a great rest of your day.
Thank you.